The series is a platform for critical national conversations about complex topics in healthcare, designed to eliminate the root causes of present-day health inequities by tracing some of the social, economic, political, geographic, and environmental roots of all of these systems that surround us. We are grateful for each of our amplification collaborators who are each working to increase equity in their environments and in their contexts. I'd like to thank them for joining us in sharing our content. We'll begin with a land and labor acknowledgement, the one that you see here before you, understanding that acknowledgement is only the first step in redressing past harms. Today, our speakers and I are joining you from the territories of the Mohican, Wappinger, Munsee Lenape, and Schaghticoke peoples. And we acknowledge that we are all living off the stolen ancestral lands of Indigenous peoples, which they have cared for since time immemorial. We acknowledge the extraction of brilliance, energy, and life for labor forced upon people of African descent for more than 400 years. We celebrate the resilience and strength that all Indigenous peoples and descendants of Africa have shown and continue to show in this country and worldwide. We carry our ancestors in us and are continually called to be better as we lead in this work. We also want to note that each of our speakers have been invited to share their individual perspectives. The views they express are their own. In the interest of open and respectful dialogue, this event includes speakers whose views may differ from the official positions, policies, or statements of the organizing institutions. We invite you today to join us with an open heart and an open mind. Before you now are our learning objectives for this conversation, and I'll note that none of our speakers have any disclosures. Today's conversation will be a bit different from our prior events in that you'll hear from two panels of extraordinary equity leaders. Our speakers include scholars, activists, physicians, and community organizers who have each tremendously contributed to the knowledge and efforts for health equity around the country. Their perspectives remind us that health equity is not just a medical issue. It's a social, economic, and political imperative. By engaging with a diverse range of voices, we can better understand the root causes of health disparities and develop more effective strategies to address them. I now have the pleasure of introducing our first panel, which will be moderated by my dear colleague, Dr. Aletha Maybank, our Chief Health Equity Officer and Senior Vice President at the American Medical Association, who will share some opening remarks before moderating the panel and introducing the speakers, of course. So, Aletha, the floor is yours.
Thank you. Thank you, Emily. Hi, everyone. Good to see you. Welcome to all that and everyone who is listening in today. Thanks for joining us. Thanks for the wonderful panel and friends and colleagues that are here to be in conversation with. It's wonderful to be here for me in New York City. This is my home, and I consider myself a New Yorker. I'm a Brooklyn person, but hey, you know, we're in Manhattan, but it's all good. But really glad to be here. So, you know, we don't have a lot of time for conversation, unfortunately, but I want to make sure we get through as much as we can to where we feel we really need to get to. So, you know, it's been over 1,500 days since the shutdown of New York City since COVID, the pandemic, and a little over 1,400 days when the majority of Americans witnessed the public murder of George Floyd in this country. And it really catalyzed this country in a direction that it really hadn't been. You know, I talk about the opportunities, and I'm going to introduce the panel in a second, but I used to be at the New York City Department of Health under the leadership of Dr. Mary Bassett, and we were given great permission to talk about racism at that point in time. This is before COVID, before the pandemic, before the public murder of George Floyd, on an institutional level. I know many people were not able to do that. And so this door and this kind of opened at this moment of time for folks to kind of step forward and make what declarations or statements, and we all know that that's not enough, but it is a critical and important first step in terms of, you know, starting to kind of address racism within your institution. We need to name it as a root cause and a root problem. And so, you know, this door opened, we seized the opportunity, and you know, I shared yesterday, I was at the Centers for Medicaid and Medicare yesterday giving a keynote about equity. And in 4 years, if we really look, there is a lot that we actually have accomplished on the institutional level, right? Many of us were organizing. I know my friend Michelle here was organizing so that our progress could accelerate really during this particular time. And there's a lot that's put in place. And there were other folks, though, and we're very clear, have also been organized and organizing, wanting to stop and impede the progress that we have been having for decades and generations, but especially within this short period of time. And so I have 4 wonderful, brilliant people here with me today to discuss kind of where we're at this moment. What do we need to do at this moment in time, knowing our very near future in terms of the context of our country, but also this really specifically in terms of health. You all kind of have touch points to health in your different spaces, and so I want to hear in that context. So first, over there, the furthest from me, Dr. Khalil Gibran Mohammed, who is the Ford Foundation Professor of History, Race, and Public Policy at Harvard Kennedy School, where he directs the Institutional Anti-Racism and Accountability Project. He is also former director of the Schomburg Center. And he co-chaired recently, if folks don't know, the National Academies of Science consensus study that was published this last fall, Reducing Racial Inequality in Crime and Justice. Next, we have Denise Rojas Marquez, who's a physician as well. And she completed her MD right here in New York City at the Icahn School of Medicine, Mount Sinai. And she co-founded the Pre-Health Dreamers to provide advising, resources, and advocacy to undocumented youth to really inspire them to pursue careers of medicine, like herself. We have Mr. Ian Hani Lopez, a lawyer. Nothing wrong with that, of course. No, just okay. Who holds the position of Distinguished Professor at the University of California, Berkeley, as the Chief Justice Earl Warren Professor of Public Law. And he writes and teaches about race, law, and politics, and is focusing a lot on the use of coded racism in electoral politics, so we're definitely going to hit that. And then Dr. Michelle Morse, who is the inaugural Chief Medical Officer and Deputy Commissioner for the Center for Health Equity, near and dear to me, at the New York City Department of Health and Mental Hygiene. And she leads the work in really bridging this context of public health and healthcare to reduce health inequities, is also clearly a physician and also co-founder of Equal Health. So thank you to all of you here today. So as we kind of do this opening part, I want you all to just reflect on how you are doing, but also, just, as you're sitting here and you're coming to stage and how you're feeling at this moment of time. But as we're kind of in this opportunity to continue our pursuit for equity and justice within the context of health and larger society, can you frame for those who are listening in, what does this moment mean? What is this moment really about? And King's phrase, the arc of, and quote, of the arc of the moral universe is long, but it bends towards justice. And how hard do we need to pull, at this point in time, really? Because I think that's, we know it's not just given, but there's intention behind that. So Khalil, I'm going to start with you, the
Sure.
furthest from you over
Sure.
there.
Well, first of all, it's really wonderful to be here and to be back home and to be having this very urgent conversation with all of you. I think one way to think about this moment, at least from my vantage point as a historian, is that there have been backlashes to racial progress of various kinds since the first enslaved person attempted to claim their own freedom. And what is unique, I think, about this particular moment is the civil rights movement has loomed so large in the historical imagination for the past 60 years. As someone who's been on this stage many times commemorating that very civil rights movement, we have distorted the actual movement itself. We have distorted its legacy. We have distorted the leaders of the movement and what they sought to gain, including Dr. King himself, to the point where we are no longer, as a society, capable of grounding ourselves in a collective set of facts about what it is we're actually trying to achieve. That's the most generous critique of this moment. The more sinister critique is that this is all a massive disinformation campaign that has been unfolding for the better part of the last 40 years. And the consequences of that are wreaking havoc on our ability to actually have a legitimate debate about what to do about premature death in this country. A country as wealthy as this should not have people dying both outside of the context of healthcare as well as inside of hospitals and within the context of healthcare. And the long arc of that story is that our system was never meant for everyone to thrive in it. It was not actually meant for everyone to benefit from it. And many of those bodies, as is true of the thousands that Harvard still holds, were part of medical experimentation for the benefit of extending white lives. And so to close on this, at least opening remark about this moment, I think the challenge that we have is that social media accelerates that disinformation in ways that when you're sitting on top of a population that is already, at best, misinformed or confused about what the civil rights movement actually tried to accomplish, adding to deliberate disinformation, which I'm going to talk a little bit more about, and I know others will join in, I consider this moment a bit of uncharted territory. I do not think of this moment as just yet another backlash that we will eventually win. I do think we will eventually win, but the terms, the context, the road to that victory, I think, are a bit uncertain at this time.
Thank you for that. I'm going to turn to Dr. Morse.
That's a mouthful. And I'm also just honored to be here. I think this is such an important conversation. To have it across disciplines is so powerful and so important. And I think my reflections really build on what the professor just shared. I think I've been reflecting a lot back on what the conditions were at the start of the Black Lives Matter movement in 2012, when George Zimmerman was acquitted, Patrisse Cullors, Alicia Garza, and Opal Tometi founded the Black Lives Matter movement, and all the gains that have happened in that time since, right? I mean, in New York City, Rikers Island closing, right? And for those of us responding to the COVID pandemic, there was unprecedented agreement that community-based organizations needed to be funded, resourced, and lead a lot of the messaging and conversation and outreach and engagement. And then at the same time, looking at where we are now, for those of us in public health, all of our funding is evaporating, right? We are in this moment where also there's a massive, organized, and very effective movement against diversity, equity, and inclusion, and they've had a lot of wins in that movement. And so it does feel like we are in that cycle, right? That violent, cyclical identity crisis that the United States seems to just constantly be in. And it also reminds me of the critical race theory movement and development of critical race theory, because my understanding of that history is that that theory was really built out of trying to understand and explain why there was so much backlash after the civil rights movement as well in the 70s and 80s. And I wonder what new theories, what new actions, what new directions are going to come out of what we're experiencing right now, this true, profound, effective, scary backlash, backpedaling, repression. I mean, the repression that's happening speaking around Gaza and what's happening there. These things are all, very difficult to manage, especially in a leadership position, especially as Black women in leadership positions. And yet, in some way, I am also hopeful that these are the exact conditions under which new frameworks, new theories, new actions, and new impact is going to emerge. And the last thing I'll say is I draw the parallel with what we're seeing in Haiti. I lived and worked in Haiti for many years. And Haiti is experiencing some of the worst conditions, political, health, and otherwise, that it has ever experienced in recent history. And the reason I mention that is because the lack of US policy towards it is also, in my opinion, a part of this backlash, right? This lack of policy. And these are the conditions under which Aristide emerged in Haiti 40 years ago. And so my hope, again, is that despite how challenging the moment is that we're in, these are going to be the conditions that create these new bursts and leaps forward in action, in theory, in frameworks, and hopefully in solidarity as well.
Thank you. Mr. Lopez, I'd love to hear from you, and especially your perspective on the law.
I just need to interrupt. I need to clarify. As far as my immigrant mother is concerned, I am a doctor. I have a Juris Doctor, and nobody's going to stop her from introducing me as a doctor. So I actually want to pick up on some of these themes already. I want to start with racism. And by the way, I teach a seminar in critical race theory, right? So I teach at Berkeley Law. I'm a critical race theorist. I focus mainly on racism. I want to start by talking about racism, but I want to ask you to consider, to ask yourself, what is your basic model of racism? What do you understand racism to mean? And now you might be tempted to say, well, there's bigotry, sort of direct interpersonal. I know a lot of you are going to say structural. You might say cultural or cognitive unconscious. Yeah, okay, I got that. But behind all of that, what's your basic model of racism? What's your basic conception of racism? And my guess is your basic conception of racism says racism is a hierarchy of white over non-white. Within non-white, again, this has been super reductive. Within non-white, it definitely makes sense to center the experience, the demonization of African Americans. We talk about this as black exceptionism, to think about the different experiences of Latinos, of Asian Americans. Okay, I got all of that. But I think our basic structure, our basic conception of racism in the United States is white over non-white. And when I say our, I mean the left and I mean the right. Because what the right is doing all the time is promoting a story that says we are fundamentally locked into a racial conflict. Some race will be on top. Which one will it be? Right? Okay, so I'm gonna come back to that story in just a second. I want to jump to a different sort of theory of racism and a different historical moment. Here's another theory of racism, and that is that racism at root is class war, waged by promoting white over non-white hierarchy. That the white over non-white hierarchy is central. It is the means, but it gets all its energy and power because it's functional. It serves the interests of society's most powerful. It is class war waged through promoting white over non-white hierarchy. Okay, so I've got that other model there, and this is, we talk about new models, but this is also an old model. This is actually when Martin Luther King, with Bayard Rustin, they organize a march on Washington for jobs and freedom, right? This connection between class and race. Okay, let me go back to this like 1963, 1964. Lyndon Johnson promises a war on poverty. He wins in a landslide. Part of that same energy creates Medicare and Medicaid. This is a moment when the country is willing to support activist government that will provide all sorts of resources, but health care to as many people as possible. And the vision then was that Medicare and Medicaid would eventually be expanded and become universal health care. Democracy worked in terms of opposing the interests of economic oligarchs who dislike activist government, who want to pay low taxes, who want themselves to control government's ability to regulate their actions, et cetera, et cetera. Democracy triumphs over the oligarchy. Except it wasn't a real democracy. It was a Herrenvolk democracy, right? A term that comes out of South Africa. Herrenvolk, a master race democracy, a democracy for whites in which most people of color were effectively frozen out of exercising real power. And it's exactly the success in challenging this Herrenvolk democracy, the 1965 Voting Rights Act, the 1965 immigration reforms, like all of the changes that we see, the very successes of the civil rights movement that move us towards becoming an actual multiracial democracy, and simultaneously open up the possibility that economic elites will be able to demonize collective government, demonize good government in racial terms. And that's the through line that gets us here. This is what Richard Nixon does when he wins. So Johnson wins in a landslide in 64. Richard Nixon wins in an even bigger landslide in 72. Talking about law and order, promising to end forced busing in the North, promising to end school integration efforts in the South. And when Donald Trump looks for a model for his American carnage speech, for his political themes, he goes all the way back to Richard Nixon.
So we're going to come, perfect. We're going to come back.
You can't take my mic!
I can't, but I can. Ian, why are you causing me problems today? No, I'm just joking. Dr. Marquez, I would love to hear, from you, and you can go anywhere where you want with this, because this is how it's going to be. I'd love to hear from you.
Absolutely. Thank you so much for having me here. Really honored to be in this panel and this space with you all. I am not a historian, so I'll give that caveat. And I'm currently practicing in emergency medicine, where I'm training at Boston Medical Center. And something so top of mind for me is violence that we see in our communities, and that being something that is of urgency right now. So I'm in emergency medicine, and just this last weekend, I was taking care of a 9-year-old who was shot stabbed in the abdomen. And I remember looking at her and seeing her eyes and feeling the innocence. She and her family do not deserve what happened. And then I remember going home and seeing images of a child who was bombed just this past weekend under Israeli attack. And that same feeling, this should not be happening to children, to families. And I thought about what our medical community, that we can do, both in this instance of violence within our communities and internationally. And I think about back in 2016, the AMA and the American College of Physicians announced that gun violence is a public health issue. And there is backlash, right? The NRA then says doctors need to stay in their lane. And so I think about how we need to stand up to powerful lobby organizations. We cannot live in fear of loss of philanthropic dollars, and how people's very lives depend on our ability to extend our influence, our material wealth to people who need it the most, our healthcare to people who need it the most. And so for me, what is top of mind is our own medical societies and organizations to be able to say to our government, we need to end our US back support for Israeli occupation, and we need to end our support for really what's happening is a genocide. And so that requires a lot of strength and bravery, and that is what I think our institutions need to look at.
Thank you. So, we don't have a lot of time, unfortunately, and thank you all for everything that you've already said, because it's already very rich. Kalia, what at this moment in time, what is, I want you to speak to the work that you're doing, because I think that that's important when I think about the context of action, right? You've already all elevated some actions in some level, but I want to hear first what you think is like the greatest threat to our ability to move forward at this moment in time, so people can see it. What is it that we need to, be really cautious of, aware of, conscious of, as we move forward over these next couple of months and year? And then I do want to hear about the work, and I want you to share about the work that you're doing at IRA, because I think it's very important.
Sure. So just by way of illustration, at this point, given there are a number of healthcare and medical professionals in the room have become familiar with Do No Harm and Stanley Goldfarb's crusade to expose what his organization describes as the lies of critical race theory and anti-racism. And if you were all to pull out your cell phones right now or online, if you were to Google search, you would read the talking points of their website. And frankly, it's remarkable and embarrassing the level of engagement on the substance of the issues. There are simply declarative statements that there's no evidence to suggest that there is bias among healthcare professionals. There is no evidence to suggest that health outcomes have anything to do with structural racism and inequality. There's a lot of use of the term of divisiveness as if that's a concern of us. Like, are we concerned about being divisive when we are defining medical education as the basis for saving lives? And there are false trades as if to suggest that any person who is being certified today to practice medicine is being trained to choose, as Goldfarb testified before Congress, colonialism over understanding cancer. So the threat, again, is not that people can't see the weakness of the counterclaims. The threat is the beliefs that underlie their own socialization as individual medical practitioners, that the real problem, which Goldfarb never names and which he never testified to, is that Black and brown people and poor people in general, to echo Ian's point, including poor white people, are their own worst enemies. That is, their individual choices that underlie the health disparities that the rest of us up here say have to do with structural inequalities, have to do with social determinants of health, have to do with healthcare bias. What he's unwilling to own is that he is trafficking in the same racist beliefs that somehow, either by dint of biology or cultural disposition or just plain old bad genetic luck, that the bodies of Black and brown people that die prematurely or that weather, whatever metaphor you want to use, is a consequence of their individual pathologies and dysfunctions and choices. That's out of vogue these days, to speak in the ways in which in the 80s and 90s it was more common, and certainly going back 100 years, it was, scientific canon. And so they don't want to say that, so they just simply make up things to discredit the ways in which we now are more sophisticated in understanding how these things work, how they come together. Individual agency does matter, but when individuals are making choices in health deserts based on the lack of living wages, based on exposure to urban toxicity, then their choices are quite narrow and the outcomes quite predictable in terms of the long-term consequences of those things. So the threat here is that people will revert to their beliefs in the face of very tacit reasons to not believe us, to disbelieve what we presented. I'll stop there to come back to others, and then I'll talk about the IRA work.
Okay. That works as long, so we.
You want me to finish up?
I think, yeah.
Why don't I finish up? I'll
Yeah,
finish
'cause
up.
you can connect
So-
the dots, yeah.
Okay, I didn't want to be that guy. Sorry, Ian.
So I should continue?
So very quickly, at the IRA project, we call it the Institutional Anti-Racism and Accountability Project, Robert Wood Johnson funded a study, essentially a qualitative study based on semi-structured interviews, including of Michelle Morse, and the work that she and others did at the New York City Public Health Agency, as well as part of the MGH system, a public clinic focusing on young people and efforts to address community violence, and finally Mount Sinai Hospital and a program that they set up to really focus on better outcomes in cardiology. All of these examples that we've published in a report that you can download point to a couple of key themes that I think are very important for hospitals and other healthcare providers who are committed to moving this work forward. The first thing is coming up with a shared understanding and a shared language of the problem. And let me just say, none of this will surprise you, but the evidence is fairly clear, although I will say, looking at applied research in this field is a fairly new thing. Most of us are very good at diagnosing the problem. It's been harder to see what works. And we need better examples of people like the work of the Boston Medical Center, which we'll hear some more about, who are actually doing things. They're innovating and piloting to be able to present to researchers like myself opportunities to look at the successes. Okay, shared language, shared understanding. Additionally, a process of accountability within the managerial structure. You have to build an infrastructure for this work to happen. This work does not happen with a DEI officer who is told, make it happen. It happens with reporting structures, with accountability, and with management performance metrics, which Michelle can talk about, where people can be held accountable to achieving those goals. Those goals, let me be clear, are situational and contextual. If you are an ER department, your goals will be different than clinical visits. If you are providing information at the ground level for long-term preventative care so that people make choices today that will improve outcomes later, things are going to look different. So, you'd have to sort of see the examples to see how each of these healthcare agencies set about this work. The next step is actually tracking that progress. If you don't use data, you're not going to have outcomes. And finally, since we have 2 minutes for everybody, and I am that guy now, the final outcome is you have to have a feedback loop. If you determine that you're not meeting your own goals, you have to actually have a mechanism to say, we're not achieving our goals, and go back to the beginning. Some of this is basic stuff, but basic stuff within the context of anti-racism and racial equity work is important and new enough that people want to see evidence before they commit to this work.
Yes, thank you for that. Michelle, since we'll connect the dot.
Well, there's a lot to say in response, and again, I really feel like this conversation and these kinds of conversations have to happen more often, especially in times like these where it is so risky to do this work, especially, again, for Black women and for people of color in general in leadership positions. And I think what you were alluding to, Khalil, especially about the fact that this can't be a one-person DEI officer effort. It really has to be a team effort. I talk all the time about how health equity work is a team sport. It really both requires multiracial efforts and diverse and expansive teams, because otherwise it does become very isolating and you can become very cynical in doing it. And that's one thing that I did want to kind of bring to the forefront as we think about, well, how do we prepare for the backlash that may continue, may get worse? How do we protect ourselves and the communities that we serve to make sure that the work that we do doesn't become, the line item in the budget that gets cut? And I think, again, partially doing it as a team effort or as a center effort is really critical. I also think it's really important, and this, I don't know if there are any communications people listening or in the audience, but if you are a VP of communications, an SVP of communications, anyone with communications in your title, you guys need to get ready. Because what I've experienced at a lot of institutions is that when that backlash comes, when the right-wing news outlet says, we heard that you're doing this health equity project, are you really doing it? We need our communications people to show up and say, yes, we're doing it. Here's a great article about how impactful it is on improving the health of these people. Or I'm not responding to this white supremacist news outlet, actually, because why would I want to get into a dialogue with white supremacists about who are attacking our health equity work? So I do feel like there is work to do in that space in particular, preparing communications staff and communications teams for how to respond to the backlash. And then finally, I think one of the most protective mechanisms, of course, is to be doing this work in service of the communities that are the most impacted, in partnership with them, not on behalf of them, not for them, not over them, but really engaging the people who are the most impacted, following their lead, and really also making sure that that is not done in a way that suppresses their leadership or suppresses the goals that they come up with. And I really feel like that is one of the hardest things to do, particularly in government, and yet it's so important, and that is how the work actually continues to have life, right? It's the organizing of the community that we're serving that is really going to make sure that it doesn't get cut in the budget, or that it doesn't get suppressed, or that we can't, actually name racism in the work that we do.
Can you also just speak to, I think the context of building power is also very critical, right? And I think you've taken a lot of action in that with the work that you've been doing about getting rid of racist clinical algorithms in medicine and building power with other institutions in medicine. And you're kind of pointed to in the country for doing the coalition effort at a local level. Can you just speak to that briefly for folks so they are aware of it?
Just the 30-second version, some of you are aware, there are clinical algorithms that we use 1 million times a day that use race in a way that conflates it with biology or genetics and actually results in racial inequities in health outcomes. Now, there are ways to use race to advance racial equity, but many of these clinical algorithms, unfortunately, are not using race in that way. The concerted efforts, mainly led by students and trainees, to change those algorithms have been very impactful. And part of what we tried to do in New York City was to say, well, we can't wait 10 years from research to mainstream practice for all of the hospital systems to change these algorithms. So we created a coalition to accelerate that work. It's been very exciting to see the 9 health systems that are a part of the coalition keep that work at the center of what they're doing and keep advancing it and measuring it. most importantly. And many of you, I think, are also aware of the fact that now we have numerous Black people getting kidney transplants that they should have gotten years ago now because those algorithms are changing. So to see that change is huge.
That's absolutely right. Thank you. Okay. It's you. It's your turn.
So I really admire all the work that's being done up here. I want to suggest what needs to happen on a different level, sort of this overarching level. I already said we need a different mental model of what racism is. We can't lose sight of the class war part. But let me now change to the narrative level. What is the single least popular political message among communities of color? Okay, so, and I wrote a book on dog whistle politics in 2014, then I did a bunch of research, ran a couple big national studies. The least popular message, political message, among communities of color. There's a lot of structural racism. We need to do what's just. We need to make this country live up to its ideals. We need to provide more resources to communities of color. And that is, you won't be surprised, the least popular political message to whites, too. But it's very important that we understand, I'm going to talk about a different frame. We need a different frame, even if we're talking to Latinos and African Americans and Asian Americans. What is the single most popular political message to whites, to African Americans, to Latinos, to Asian Americans? The single most popular political message. We're all in this together trying to take care of our families. Billionaires and the politicians they fund try to tear us apart so they can rig the system. If we build power across racial lines, we can take care of our families and our communities. That narrative is the single most popular political narrative available right now. It's part of what's happening with DEI. It's part of what's happening with all these attacks on critical race theory. What the right is saying is, hey, some race is going to come out on top, pick a side. If the left responds by saying, in effect, we need to shift more resources from society at large to communities of color, a lot of white people hear the right's narrative confirmed. And a lot of people in communities of color hear a story in which they have to accept that they are hated and that their children's lives are truncated because they're hated by the dominant group in society. And they don't want to hear that message. If instead we're saying to people, we're doing this work so we can take care of all of our communities, white, black, and brown, and the main threat that comes to us is from oligarchs and demagogues, and when we reject the lies and stand with each other, we can actually take care of our families. Right? That what we mean by diversity, equity, inclusion is an integration that creates a multiracial, egalitarian society in which we can all thrive. That's the sort of framework, that's the sort of communication strategy that people really need to look into.
Thank you. Denise?
Yeah, thank you so much. And I've been thinking about what a threat to progress and the equity that you all are talking about. And for me, going through training in medicine, I've one threat that I've identified is the idea that we must stay silent until given permission. And I'll explain. So when I was in college, I am still undocumented. I am a DACA recipient, and then my peers told me, and an advisor said, you should not advocate for the undocumented community, not until you're a doctor. They said, get good grades, get to the top schools, and maybe a decade later, maybe then you can say something. And I didn't have a choice because there was no medical school that accepted someone like me. So in order to be able to make a path, I had to carve it out on my own, and I had to speak up. And I spent years starting a nonprofit organization, Pre-Health Dreamers, that now has created significant change for undocumented young people who are aspiring to become healthcare professionals. And that is something I'm extraordinarily proud of, that has diversified our healthcare workforce. And fast forward into medical school, again, I am told to be silent this time about different things. I trained here in on the Upper East Side, where patients with private health insurance are sorted into the private practice, and patients who are on Medicaid are sorted into a resident-run clinic that often has longer waiting times for referrals, and I could not believe what I was seeing. I thought that segregation in our healthcare system had ended with the Civil Rights Act and subsequent legislation, and yet nobody was talking about it. No one. And we actually ended up creating curriculum in our medical school to name it. We started having a town hall and forums so that we could teach ourselves. This is not something that we wanted to perpetuate to our next generation. And I thought if we waited until we were the CEO of a hospital, we would have spent an entire generation learning that the poor are for training and that they are less deserving of health care. And in order to, I think, counter the racism that we see, we need to unlearn that, and we need to stop that inherent sort of messages that are passed down throughout our entire career of training.
Yes, thank you for all that you've done and the work in your advocacy. So we literally have like time's up, it says. And you know, it's interesting as each of you just spoke, everything that you said, you know, we have all been part of writing strategic plans, providing frameworks of what the actions are, and you all elevated that. You know, it's kind of like the strategy is known, and it wasn't new to us putting it forward. Other folks have said it before in terms of accountability and data, leadership, advocacy, not being silent, centering those who are not just their voices, but the people themselves who are the most marginalized, proximate to the problems, and hearing that challenging and disrupting narrative work. All these things are written in our strategic plan. It's, you know, it's just fascinating that we have the solutions amongst us, and we need more accomplices. We need to build more power. We need more of us stepping up into action at this given time. We know what we need to do, and we just need to all do it together. Well, thank you.
Thank you.
You know, I really, I feel blessed, and I'm just really grateful for the conversation today. Thank you all for listening in, and we look forward to the next conversation.
All right. Thank you so much. What a group of humans to follow in conversation, right? I have the distinct pleasure of being joined on stage by 4 additionally amazing humans. To my far right is Dina Hayes Green, who is the co-founder of the Racial Equity Institute and partner at the Groundwater Institute, from whom I have learned an immense amount in our time knowing each other. Her extensive public service includes roles as a Human Relations Commissioner, International Civil Rights Center and Museum Board Chair, and the Guilford County School Board Chair for many years now. She's nationally recognized for her commitment to social justice and has served on the National Academy of Science and Medicine Unconscious Bias Committee, among many other prestigious roles. To her left is Mr. Andre Perry, who is a senior fellow at the Brookings Institute, a scholar in residence at American University, and a professor of the practice of economics at Washington University. His recent scholarship at Brookings has analyzed Black majority cities and institutions in America, focusing on valuable assets worthy of increased investment. Next, we have Dr. Alistair Bell, who is the president and CEO of the Boston Medical Center Healthcare System. Alistair received his medical degree from the University of Oxford and Master of Arts in Physiology from the University of Cambridge in England, and has an MBA with distinction from Harvard. He also currently serves as the co-chair of the board for the Boston Children's Chorus. And then immediately to my right here is Shelby Chestnut from the Assiniboine tribe, who is the executive director of the Transgender Law Center, which is the largest national trans-led organization advocating for a world where all people can define themselves and their futures. They have over 20 years of community organizing, political advocacy, and leadership experience in the LGBTQ and anti-violence movements, and throughout they've spearheaded leadership development and social change within and for Black, Indigenous, and people of color and their communities. And so I'd like to start with giving you each a little bit of space to reflect on some of what we've just heard and to share a little bit of how you're coming into this moment, thinking both big picture and in the conversations that we've had throughout the day, sort of where are you coming in? So Dina, maybe we'll start with you.
Sure. One, it was just wonderful hearing from the panelists, and it's so amazing to be here in this sacred space having this particular conversation. I was talking to Dr. Maybank earlier, and just saying that is a reminder, this institution here is 99 years old, and it's a reminder of us that this is the time for us to do our work, because people did their work. And this work has always been done in a climate of resistance and oppression, so this isn't new. And I think we've taken so much for granted because people created an environment under which so many people are able to do this work inside of systems and institutions. And I think history is our greatest reward for the research to understand how we got here. When we think back to back in the 70s, we can really go back centuries, but if we just think back to the 70s, it was just these sort of architects, and not from historically white colleges and universities. I think it's really important to provide that context, but from the institutional leaders from historically Black colleges and universities, from Tuskegee, from Morehouse, from Meharry, from Xavier, later joined by Drew and FAMU and Hampton and Howard and Texas Southern. I don't want any alumni dinging me in a minute saying, you left us out. But it was them that, people from the sort of civil rights movement that understood what their job was inside of those institutions, that did their report, did their studies, took that to Margaret Heckler, who was then the Secretary of Health and Human Services under the Reagan administration, around the burden of death and these racial and ethnic disparities in healthcare, and not convinced that she was going to listen to them. And so it was the Association of Minority Health Professions School Leaders from HBCU architects that generated that report, that led to the Office of Minority Health, that led to the Malone-Heckler report, that led to the Institute of Medicine's unequal treatment report, that put pressure on the AMA and the CDC and the NIH and the institutions, public health, schools of public health, medical schools, healthcare systems to do something about this. And so we have to remember how we got here. People in power didn't wake up and say, oh, this is wrong, we need to address these inequities, that we need to do something about this. It's people who organized and pushed systems into accountability. And I think, we've enjoyed some opportunities, but now it's time to do some hard work around this.
Thank you so much, and I share that feeling of the importance of the place as well as this moment in time. Shelby, maybe you could go next, share how you're.
Yeah.
How you're coming
Hi,
into
everyone. I'm still a little distracted. The Trump verdict came in, so he's guilty. All counts. Anyway, sorry to cause mass upheaval, but I was thinking a lot about. I spent the last 15 years in New York before I left. And I remember moving here and was introduced to organizations like the Sylvia Rivera Law Project, Queers for Economic Justice, which has now shuttered its doors. And there was a campaign to get Medicare and Medicaid to cover transition-related surgeries. And this was just like a decade ago. This wasn't that long ago. And people won. And I keep thinking about the disability rights movement and their slogan of like nothing about us without us, and how this moment that we're in with trans healthcare, I don't know if y'all have also turned on the news and saw that every state, it seems, is trying to restrict trans people's access to medical care, particularly trans kids, and then their parents who are supporting them as parents should be supporting young people. But this moment that we're in where, much to sort of what you were lifting up, like the history of LGBT organizing to get rights won. And it wasn't like lawmakers are actively seeking to support LGBT people, because they're not. That's just the truth of the matter. We have insurance coverage that covers me going to the doctor because trans people demanded that that should be covered. And that was decades of fight and battle, you know. But even just this week, I got a text message from a good friend who's worked in government here in New York State for a long time. They have a young sibling in their family who got a letter denying them to go have insurance cover their transition-related top surgery. It's 2024, and a private insurance company is denying that. And I'm saying all that partly to just contextualize that, even in places where we have, New York City, a lot of rights and a lot of really equity in some regard, just the massive inequity that there is. And I think so much about the people who fought to get Medicare and Medicaid to cover certain procedures here in New York. And it wasn't just mainstream gay Inc. It was homeless, black and brown, queer and trans women and poor people. And to see sort of what's happening nationally, just what rights are on the line for us. I think I'm coming into the conversation a little bit emotional because there's just so much on the line for where we're at.
Alistair?
Sure. Well, just thank you again for having me here. I'm really honored to be both here and on this panel with this very esteemed panel. I'm also proud to represent actually all the staff and physicians, many here, in fact, at Boston Medical Center, who share a very, very deep commitment to equity in all its shapes and forms. You know, personally, coming out of the last panel, I don't know if I'm alarmed or activated. I certainly feel, I'm not an academic. I sort of read things, I don't sort of study things. And so my job, in a sense, is to try to convert the world as that we're experiencing it into things that happen in an organization, to steer and lead a group of very passionate people towards goals to kind of keep the organization going, to seize all of the opportunities that we have. And so I find myself doing a lot of sort of translation again of how does this moment intersect with our work, on health equity. And we are, Boston Medical Center, as many of you will know, is an academic medical center, but it also serves a disproportionately low-income patient population and predominantly communities of color. And so I sort of think our clinical excellence, our commitment to equity is really a sort of an intersection that provides this opportunity for us to move past describing the problem. And so that's what we at BMC are spending a lot of time thinking about is, we know, the data is it's there. You can choose to ignore it if you wish. We do not. And so we look very, very seriously at the fact that black patients in Boston are 1.5 times as likely to die prematurely of cancer. The infant mortality among black infants is 4 times that of white infants within Boston. And we spend a lot of time asking very inquiring, searching questions about both the system that we operate within and how can we change that, the work that we do within the organization, how do we lead to, in fact, some of these outcomes by not being demanding enough of the resources that we require to actually deliver. We, as an example, half of the patients that we serve are on the Medicaid program. That for the business people here, that reimburses 60 cents on a dollar of cost. So you start off at an economic disadvantage and under-resourced, and then someone says on top of that, hey, can you, by the way, take on, decades, if not centuries, of racial injustice and the consequent health outcomes that are related to that, from that position. Now, I will say that feels like a very daunting task, but I think it's our job, it's my job, certainly it's the job of the team at BMC to convert that into actually things we can do, answers that we do have, write about it, disseminate it. And so I'm sort of both, again, as I come back to, sort of alarmed by the moment and also activated for us as an organization of what we can control and how we can contribute at this moment to try to provide some answers and way out. And my hope is that at some point, ultimately, it's the bending of the arc, or what was that quote? You know, it's like, we will bend it, and at some point, like, we're gonna need real answers there. And so I sort of fundamentally am optimistic about that, but it sure feels very difficult at points.
Yeah, thank you. We are definitely gonna come back to ask each of you for some answers and solutions, or how you're bending that arc. But Andre, do you wanna share how you're coming in?
Yes, first of all, thank you for having me. I come to this work as a researcher who is focused on changing policies that extract wealth and opportunities from communities. Most people know me through my work on housing devaluation. In 2018, we found that homes in black neighborhoods are underpriced by 23%, about $48,000 per home. Cumulatively, there's about $156 billion in lost equity in black communities, places where the share of the black population is 50% or higher. And I always put that in context. $156 billion would have financed more than 4 million black-owned businesses based upon the average amount black people use to start their firms. It would have paid for more than 8 million four-year degrees based upon the average amount of a four-year public education, replaced the pipes in Flint, Michigan 3,000 times over. It would have covered nearly all of Hurricane Katrina damage. It's double the annual economic burden of the opioid crisis. When you ask women how they pay for their IVF treatments, most pay for it through the equity in their home. When people want to run for office, it comes through, and they don't want to take out a loan. They use the equity in their home. I say all that to say that people are losing wealth and opportunity, and wealth is by far the greatest indicator of economic security and one of the strongest predictors of health that we know. And wealth is extracted without anyone wearing a white hood or a tiki or carrying a tiki torch. It's done through everyday practices that we live with. So for me, I come to this work knowing that we have the evidence to make the changes we need, and we have the policy solutions. What we need is a mobilized populace to do so.
Thank you. Thank you each for sharing that. And I'd like to turn to some of these solutions, right? To some of the places, bright spots where we've seen power building be effective in advancing equity, not just for specific communities, although that is important, but for everyone. And so, Dina, maybe I'll start with you. If you could share some of the ways in which you've been engaged, perhaps you can share a little bit about the Greensboro Health Disparities Collaborative, and some of the ways in which the redesign of systems can actually benefit everyone.
Yeah, thank you. The Greensboro Health Disparities Collaborative is a collaboration that was community-driven and community-led by a group of people who spent some time deepening their analysis around race through the Undoing Racism workshop, first experienced by the People's Institute for Survival and Beyond, the Racial Equity Institute, the Groundwater Institute, and people that had been invited and brought in and harassed, to come in and have that experience. And having that shared analysis and being able to think about our systems differently and being able to think about why does every institution have poor outcomes that have the same pattern and the same, just sort of the same populations. There's got to be something, unless you believe, I think like the earlier panel said, that there are these beliefs that people are so deficient that they can themselves produce these inequitable outcomes. And they didn't believe that. And so, sought to, to ask why, one, how do we identify these different outcomes? And then two, how do we partner in a truly equitable way, particularly across the research continuum? And so it led to this collaboration that included the healthcare system partners and the academic partners. And so they embarked on a series of studies. One was just sort of this investigation to see, do we have racial and ethnic inequities in Greensboro? And out of these focus groups, they decided to focus on breast cancer because it was the thing that kept coming up, that someone had a family member or a friend, or they themselves had experienced that. So in our community, in our healthcare system, are there differences in diagnosis and treatment outcomes? And after getting that investigation done, they found out that there were disparities in early stage lung and breast cancer treatment completion rates. And so this was a 21-year process, and it took a lot. But the focus was on systems, not on fixing people. Our our Fish Lake groundwater approach and analysis that we use in our work, that the outcomes that we see consistently and perpetually in our systems and institutions point to something happening in the lake, something happening in the systems that needs to be addressed. And what they found was that the healthcare system is so fragmented, that the technology wasn't integrated, that it was months, weeks or months before people found out that someone had missed a critical milestone in care, like radiation, chemotherapy, even scheduling an appointment for surgery. They found out that Black patients were more likely told over the phone that their biopsy was confirmed, or that there were delays in scheduling surgery, or they were told to monitor a lump. You know, let's just keep our eye on that instead of saying, let's rule that out. And so after they got that information, it took 3 years to get the technology, this real-time cancer registry and a trained nurse navigator to say within 24 hours, someone is aware, you know, that Mr. Jackson missed, you know, his chemotherapy appointment, to get to Mr. Jackson and to find out what happened. After 21 years and so many interventions that you can read about this on the Greensboro Health Disparities Collaborative website, they were able to close the treatment completion rates. And you know, in early stage breast and lung cancer, treatment completion is life-saving. It's life-altering. They were not only able to close the racial gap in treatment completion, but they improved outcomes for white patients too. So when you fix the system for one group, you improve that system for everyone. We believe that systems can't operate optimally for one group and poorly for another group. It begins to erode the competency of those institutions. And so the ACCURE project, Accountability for Cancer Care Through Undoing Racism and Equity, has produced those incredible results. I thought people would be, you know, beating a path to the door, but even when a system gets what it wants, systems are so entrenched, you know, bureaucracy and power, and turnover and fragmentation and all the problems of systems and cultures, that it has been very difficult to institutionalize that. And I'll just say more later that if we don't have community that is organized, as you were saying, then those things fade as though it never happened.
Yeah, thank you so much. Shelby, do you want to speak to some of the community organizing and the ways in which that can help to change systems and structures in ways that are durable?
Yeah, I can. I'm thinking a lot about the Violence Against Women Act, and it was the first sort of landmark federal legislation that was inclusive explicitly for LGBT people. And, you know, we did it based on the premise that, well, because it's not excluding it, we just assumed it was included. So we did a whole, you know, decades of lobbying to basically get to a point where it was explicitly inclusive. But, you know, I want to lift up, we were talking about North Carolina in the green room. We had a green room downstairs in the basement. And talking about, who here remembers House Bill 2 in North Carolina? So it was the first sort of big main stage bathroom bill that was saying trans people, we're going to limit how you're supposed to use the bathroom because everyone's safety is really not okay if trans people use the bathroom. And, you know, I remember the Attorney General at the time coming on national TV saying, like, trans people, we see you, we're here for you. And, you know, quickly it became an economic sort of battle in North Carolina. And there was the NCAA games, I think. NBA. So they were like, we're going to pull out if you continue to push this forward, you know, and it became about sort of, well, federal dollars will be limited if you all try and move this ban forward. You know, fast forward a decade later, you know, they didn't win on bathroom bills. They didn't win on trans kids playing sports. And now they're vehemently trying to basically say trans people as a whole are not deserving of health care, but particularly trans kids. And I think they keep going after the next sort of thing, partly because we're winning. And trans people are organized. We are doing what it takes to block these bills, you know, and in worst case scenarios, litigating in states. TLC, we're litigating in the state of Texas because they're trying to ban trans kids from accessing healthcare. And, you know, at the same time, you go to a place like Texas, which, has anyone here ever been in the Texas legislature? So it's wild, right? I mean, it's like Texas to the umpteenth degree. So you go in there, you're inevitably lost, And I've gone down there probably 5 or 6 times in the last 4 or 5 years. And every time I've gone, it is packed with kids that are trans, with trans adults, with their families. And it is an all-day, multi-day affair. And you start meeting people, and you're like, how did you find out about this? And you meet all kinds of people. And the first time I was ever there, I met this young girl. She's probably now in high school. And I had Transgender Law Center, TLC for short. I had my name tag on. It said Shelby TLC. And this little girl said, oh, you work for TLC? And I was like, yeah, I help trans people like you and me. And she's like, oh, never mind. And I was like, and she was like, I thought you worked for the Dinosaur Channel. And so she's a 9-year-old trans kid living in the state of Texas who's actively seeking to restrict her very existence. She's got a supportive family, and she's in the Texas State House fighting these bills, has no idea to the degree that they are debating her like very existence. And she's more concerned about like getting swag from the Dinosaur Channel. Like that's actually the world that we're living in, and how organizing, I think, is making it possible so she can live. And I hope she's like thriving in high school. I imagine she wouldn't be if she was that sassy at 9. I can only imagine at high school, but like that's actually the sort of what organizing to me is the end goal, not to just all be this sort of political sort of forward motion, yes, but so kids can just go to school and like exist.
Yeah, absolutely. And Andre, do you want to jump in here and speak to some of that? I think the connection between sort of investment and schools and the organizing that it can shape the ways that investments are made.
Yeah, but one of the things I do want to acknowledge that outcomes vary widely by place. So in many places, we did a study looking at life expectancy of different populations, one particular Black Progress Index, where we looked at the life expectancy of Black people compared to other Black people in different places. And when you do that, you control for many variables, you come up with your social determinants, you find that there are many Black places where they are living well beyond the national averages. And there's no surprise when you look at everything from housing outcomes, educational outcomes, a number of factors, that Black people are well beyond national averages. And it just didn't happen by accident. There was civic action in many of these places that created the overall environments. Now, I remind people that many of the policies that are negative, like in housing, we have redlining. That was started at the local level. It was not started in the federal level. It was codified and resourced at the federal level, but it started at the local level. So I say that to say there are solutions in locales that are actually doing a lot of good, but they need to be codified and resourced. Organizations like the AMA have a responsibility of uplifting the bright spots in our communities, because too often we get into rooms like this and we only show the disparity, right? And we never look at the very real successes that are happening not only in communities, but actually within organizations. There are people, I can't say enough about the work Aletha that is doing all across the country that goes unnoticed, because we're so focused on this big black-white comparison, and we can mask the real progress. I will never skirt the issues at play, but I also will not skirt the people and the places that are doing the work. They're not, I mean, we have solutions everywhere. We need them resourced, codified, supported.
Yeah. Thank you. Could not agree more. Alistair, do you want to speak to some of the ways that, I mean, in a very local context, BMC is resourcing or identifying resources to address some of the inequities that show up in our communities?
Yeah, sure. So I guess I look at it a little bit as we have a set of outcomes, and then we have a system writ large within healthcare, and then more broadly within our local and national society, if you like, that is designed to get those outcomes at the moment. And so what we have spent actually quite a lot of time in Massachusetts as a whole, but certainly for BMC in Boston and having an influence at the state level on is, yes, there's a lot we can do in terms of looking at the work we're doing within our organizations, and we see things, policies that are in place. I mean, discriminatory government policies, we saw that in the COVID vaccine. When it came to crisis standards of care, we saw clinical algorithms that would systematically not allocate resources to Black and brown populations. So like there's all of that, if you like, that's a whole thing in and of itself that actually we as the medical community really have to like own and try to like interrogate much more and be more honest with ourselves about how we are generating how we are part of that very system that is generating these disparate outcomes, acknowledging that there are pockets of great success as well. I spend a bit of time, though, thinking about, like, well, what's the system outside of our organization? How does that intersect with us? And so, for example, in the last 10 years, we kind of work very closely with the state on re-engineering the entire mass health program, that's a Medicaid program, into a vertically integrated program from payer to provider. So, for example, every primary care patient in our system on Medicaid is in our health plan. Now, that will scare the bejesus, by the way, out of a lot of safety net providers, but it actually provides this set of global incentives to like go after a whole set of things that actually, as a healthcare provider, you wouldn't otherwise do. So I'm actively interested in housing, because unhoused people like cost huge amounts of money. Like and so you could, I have a certain value set, but you could drop any executive into my position just about at the moment, and they'd be like, oh God, we got to do something about housing, because like unhoused people drive massive amounts of healthcare expense, like literally the cost of apartments, over a couple of years. We have looked also at, for example, we are, as I mentioned earlier, systematically underpaid, but we get support from the state in the form of supplemental payments. It's sort of, we get paid in a different way. And so, well, we needed more of those, and so how are those paid for? And so, well, everyone's like, well, we want pay for performance, and so we worked with the state and said, well, how about pay for equity? And so now, as an organization, like every year, we have $80 million coming in that is determined by equity and our performance against equity things. And so I give those examples more as like, there's a lot that you can do in like pushing and prodding on these systems that exist to actually create a redesigned system that means that actually it's not just about, do you have it in your heart, but it's actually like, are there economic incentives that are driving towards doing the right thing for organizations? And when you start paying for that, and the important thing for me as much as anything is, yes, that's true for BMC, and that's part of us doing the right thing and being rewarded for that, if you like, so that we can continue the organization. But it was policy. It affected every single provider in the state. So everyone who got a supplemental payment is now paid for equity on that. Everyone is in the ACO program in that. We are now backstopping health insurance for 40% of the Medicaid population in Massachusetts and bringing our research and insights and programs into them. And so I think part of it is sort of, in terms of taking action and system change, it's yes, what we do internally as sort of physicians, it's also how you advocate outside of that and work to reshape policy to create a structure that gives a set of incentives for people to be working on the right things with the right level of intensity, where there are business cases for actually doing these things. If there's a moral case, there's no question about that, but how do you have a business case that creates resource availability that goes against these type of problems? And I think that that's what we need to be thinking more broadly, like within the healthcare sector as a whole.
Can I just add something like to that? Another study that we're going to actually release a report on that. We looked at well-being of Black people. We tried to correlate that with well-being of other groups. So as well-being for Black people increases, so does the well-being of other groups. So when you invest in housing, when you divest from criminal justice, when you invest in workforce, everyone's well-being improves. And so again, this goes to a little bit about what the last panel talked about. There's been just such a horrible branding of what equity is. Equity is good governance. Equity is saying, hey, we do believe in the American dream, and we're going to make sure everyone achieves it. And so for me, this idea that one group's well-being is in competition with another well-being is false. It's false. And it is very true that anti-Black racism was used primarily for some white people to hoard wealth and to maintain a level of dominance. Today, we need to address the anti-Black racism that is still in our policies, and we need tax policy changes so that people can get the wealth and help themselves, or help be able, so they can recover themselves. I say this all the time. If you, the criminal justice system, let me tell you how jacked up the criminal justice system. It is the #1 drain on healthcare budgets in so many states. The injuries that people occur in prison is draining money from higher ed, from all these other discretionary areas. And so this idea, we got to think about this pie can grow. The pie can grow. We are not in this weird racial zero-sum competition. But that is the mindset we have installed. That is the trick of white supremacy. To say that if I give this Black person, I'm taking from you. Black people represent about 14% of the population, but only 2% of employer firms. If the share of the employer firms match the Black population, there would be more than 800,000 more businesses, 4 million new employees, trillions added to the economy, innovation, growth all the way around. And I don't like making the economic case all the time, because we still need to make a moral case. But there is money lost because people are willing to cut their racist nose to spite their face every single day.
I'm being reminded that we are drawing close to the close of our time together, and I think I would love to hear, we have the luxury of a relatively large platform here today. And so if you would offer your thoughts on one, maybe two things that you would ask of everyone who's here with us listening into this conversation, what would you ask them to do as we leave this conversation further into an election year, further into our work, whether that is explicitly to advance equity or whether we are a part of health systems with a different role or a different title? What would you ask of each person listening? And Shelby, I'll start with you.
Yeah, I got some clear asks. So I think we're living in a time where states are going to ban healthcare for trans people in certain states, and people are going to have to go across state lines and figure it out. And I actually think doctors can play a frontline role, medical providers as a whole can, to think about, what am I doing to better integrate trans people's care into my medical practice, like in a bigger sense, not just in an individual sense. I think oftentimes our healthcare is treated like it's some special thing over in here that is super unique. It's not unique. I've kind of been making the argument for a long time that, gender affirming care or transition related care, it's just healthcare. We all go to doctors for things related to our gender. It doesn't matter who you are. Literally, it's just the fact. That's one. And I think the other thing is start talking about what your contingency plans are when you're in states that are going to ban it. I lift up New Mexico. And New Mexico, the Southwest region, has become really the island in the sea for trans healthcare. But what people aren't talking about is that the state of New Mexico, the health disparities there, they're extreme. I mean, it's one of the poorest in the country. So people can access healthcare, but who can even access healthcare there in the first place? So what are we, I mean, I do make the economic argument that like we're not investing in the places that need this the most. And this is the places where people are gonna have to go to seek medical care safely. And I think the sooner we can accept that people, unfortunately, are gonna have to travel, the better we can equip the sort of medical field to understand this. And also, the last thing I will say, very, very quickly, I see time and time again major medical institutions shying away from giving care to transgender people because they're worried about what the government is going to do to their ability to practice medicine to everyone. And I call bullshit, if I'm allowed to say that, because it's like you have an obligation to provide medical care to the people that deserve medical care. So that's kind of my thinking on where we're at.
Alistair?
I guess my ask would be, this is AMA, so I guess I'm talking to physicians here. I'm a physician once upon a time. Just to recognize, you know, I think a lot of physicians across the country are feeling that they are kind of stuck. They're enjoying their jobs less, they're burned out, they feel part of variably kind of corporate sort of machines, if you like, as healthcare has become more systematized. I would really implore physicians across the country to recognize that you have a voice, to use your voice, to be inquiring and demanding of things that you were taught. The prior panel referenced this. There's stuff that literally you were taught that is just outright wrong. To be much more inquiring and demanding of that, and to really actually interrogate your personal actions in your practice and those of your organization in which you work, and recognize that if you are truly doing your job, and you know, we made an oath to treat people and to do the right things by them and do no harm and do all this other, and that actually you may be doing harm, in fact, by not staring in the face the outcomes that you see in the community, the disproportionate access, the way that different organizations approach different problems. And I think you have a voice, and I think that you should be using that voice and carrying that message forward. And it's a sort of a message, if you like, of personal empowerment. At a moment where it can feel very collectively paralyzing. There's a lot that I think each big change has happened with individuals acting. And I think if physicians across the country acted on this topic and took a stand and said, actually, yeah, we actually need to rewrite what healthcare is about, and actually we need to change, and we aspire to have a different set of outcomes, I think we have such a leadership role to play there. So I hope people listening to this will kind of think about that and think about how they carry their voice forward on it.
Yeah, yes, I think the AMA should join forces with major higher ed groups to cancel student debt and medical debt simultaneously. You can clap that up. And the reason why I say that, again, wealth is one of the biggest predictors of health. When you improve people's wealth outcomes, you automatically improve their health outcomes. With that said, I also think the AMA should join forces with fair housing groups to create new mortgage products that don't require a down payment. We have special purpose credit programs that people are doing everything that they're supposed to do. They just don't have the down payment. And simply because their grandfather could not use the GI Bill, or that they lived in red line neighborhoods, and so they did not get the intergenerational wealth transfer as some of our white peers. So if we can figure out new products that will give people assets and cancel debt that, by the way, they're going to die with, we can improve people's health outcomes along the way.
Yeah, and I would invite people to think like an organizer, right? Because organizers know that it's movements that have led to the incredible progress that we've had in this country, and it takes massive people, you know, it takes a lot of people to be brought into a vision of what this country could be and that we can get what it is that we really want. And I think one of the things that I love about the Groundwater Institute is that we've had to let go of these ideas that corporations don't believe in liberation, that physicians don't believe in liberation, that police officers don't believe in liberation, and that we can work across the ecosystem of these systems and bring people into an understanding. I love what attorney Dr. Ian Haney-Lopez said in the last session, is that we've got to, you know, we've got to learn from what the last 10 years of our sort of movement work and organizing. We made some mistakes, you know, and we've got to learn from those so that we can reach more people, and we can bring, because there's so many people that believe in what we believe in, that share the values and the vision of equity and justice and liberation and freedom and a multiracial democracy. And it's on us to do that. You know, we have to make that moral arc bend. It's not going to just do that on its own. We have to create the conditions under which change can occur.
Thank you all so much for your brilliance, for your time, for your energy. And you could all have a seat. I'm just going to close us out very briefly. 2 minutes, I promise, and we'll wrap up. I just want to extend our sincere thanks to everyone who joined us for this conversation, to our speakers, to our interpreters. Please give them a round of applause. To the Schomburg Center, their staff, all of our vendors and partners, and to each of you in this audience. We truly appreciate all the thoughtful questions that we know came through, and with our short time, we did not have a chance to answer. Thank you for sharing your thoughts with us. We'd love to hear what you have to say about this conversation today. If you would like to use this QR code or on the website, you can find the link to this post-event survey. You'll also be able to claim CE or CME for your attendance today if you are a healthcare provider by visiting the website and following the links there. A recording of the conversation that you just heard is available on our website and on the AMA's Ed Hub, and we'll share a list of some of the resources, articles, reports that were mentioned here today, so you have those, as well as a visual summary of the event that was created by public health artist Rio Holiday, who's working in the background as well. Recordings of prior conversations in the series are also available on our website, and we hope that you will stay tuned for more to come. We have lots more in the works. So thank you each for joining us today, and I hope you have a wonderful rest of your night. Thank you.